Hello, everyone. This is Siddharth Damber from Chicago Arthritis and Regenerative Medicine. Thank you for joining today's webinar. Today, we'll be talking about regenerative medicine treatments for arthritis, tendinitis, injuries, and back pain. I'll be speaking for about 30 minutes, 20 to 30 minutes. If you have questions, please leave them in the chat or in the questions section. And as we go through this, I will continue to answer things. So what you will get from this webinar, you'll learn more about the best available non-surgical treatments for arthritis, tendinitis, injuries, and back pain that do not require surgery. That includes using your own cells, what is legitimate in the field of regenerative medicine, and how to choose an appropriate physician and clinic for your needs. And again, if you have any questions after today's webinar, we'll give you ways that you can contact us. Probably easiest way is if you just go through chicagoarthritis.com. So the big question, what would you do if your pain was controlled? How would your life improve? What exercises would you restart? What activities with family and friends would you participate in again? So a bit about who I am. My name is Siddharth Damber, physician here at Chicago Arthritis and Regenerative Medicine, specialist in rheumatology, specialist in image-guided musculoskeletal injections, in practice since 2008, involved in regenerative medicine since 2008 as well, and within the Regenix network, which is the largest group of physicians working with the same protocols in regenerative medicine in the world. So my personal journey in regenerative medicine really started with my own shoulder. Essentially, I played tennis when I was in high school. In my training, in my medical training, I was taught musculoskeletal ultrasound. That gave me an insight into tendon and ligament injuries that was very different, and started to realize that the typical treatment modalities that we were utilizing were insufficient for patients and that we needed better options. That's what got me initially into platelet-rich plasma and then eventually into using people's own bone marrow stem cells. So traditional care for musculoskeletal conditions, and that includes whether you're talking about tendinitis, sprains, arthritis, back issues. Essentially, the traditional care is mask the pain until things get so bad and so severe that now you're just waiting for eventual surgery. The equivalent of that in, let's say, diabetes care would be if you just waited until you had your first heart attack or stroke. Nobody would recommend that, and that's a terrible way to proceed. And so I do not recommend that for patients with arthritis and tendinitis. So problems with traditional care, with pain medications, they don't fix the problem. There's lots of side effects. Traditional injections, which include steroid injections and nerve blocks, they can actually, while they can give pain relief short-term, they don't give it long-term, and they can actually cause a lot of other issues long-term as well. So you want to try to avoid those as much as possible and find better options. Surgery, it's appropriate for people that have certain really advanced conditions or severe conditions, but surgery gets overused for a lot of things that really don't need it. And for things that are milder or moderate. And what that does is you're taking a treatment modality that has higher risk, that can accelerate the arthritis process, that can cause more instability. And a lot of routine surgeries, including knee arthroscopy, if you already have arthritis, have not been shown to be more effective than just physical therapy alone. And so there's definitely better ways to approach things before they get too severe. And regenerative medicine is a key part of that. So in searching for better options, we need treatment options that avoid a lot of the side effects that you see with traditional care, that are lower risk, that improve the actual cause of the problem, and that can lead to long-term improvement. So imagine reducing your pain and getting back to the activities you care about without surgery or pain medications. So regenerative medicine is the process where you utilize your body's own cells to treat your musculoskeletal conditions. It utilizes a normal healing process. A normal healing process, after you have, let's say, something small, even like a cut on your finger, you have platelets that infiltrate the area. They first stop the bleeding. They then release growth factors, which then help to stimulate your local stem cells, which then through a process of inflammation, then starts a slow process of cellular healing. So tissues that have either poor blood supply or been repetitively injured tend not to heal very well on their own. So by using your own cells under high-level image guidance, we inject those same cells into those tissues that are not repairing very well to cause that normal healing process to occur. So why regenerative medicine? You're really treating the source of the problem, which I'll talk about a little bit later. It's safer than surgery. It's effective for most musculoskeletal conditions. And for those of us involved in this, we've been doing this long enough, really feel like 80% of what you see that's being done by surgery right now will eventually be taken up by regenerative medicine. How does it work? You can optimize damaged cells, essentially cells that have been worn out over time are no longer creating the right proteins or enzymes that you see in a healthy joint or tendon. By injecting your own cells into that area, you can get those existing cells to start pumping out the right kind of proteins. You can improve strength and stability of supportive ligaments, tendons, and other tissue structures. In addition, you can reduce chronic inflammation, and you can also improve neuromuscular health as well. All these things result in reduction in pain, improvement in function, which then overall leads to better quality of life. So what really makes a musculoskeletal regenerative medicine expert? There's a number of things. Number one, they need to be a musculoskeletal expert. And what that means is there's someone who really should be focused on arthritis and tendinitis. If your physician is jumping into one room to treat high blood pressure, into another room to do a Botox injection, and then into your room to then do a knee treatment, that's not a musculoskeletal expert. That's someone who's kind of hitting a lot of different things. In medicine, you need to be focused. The more focused you are, the more of an expert you can become. Being a master of too many things makes you not an expert of the one thing you need to be treating. Number two is they should be a non-surgical musculoskeletal expert. Most of my orthopedic colleagues have great training and experience in orthopedic surgery, meaning that they're very good at the surgical part of things. They don't really have the right kind of training when it comes to image guidance and regenerative medicine that it takes to really be an expert in this field. Number three, they should be using image guidance for all procedures. I have quite a few colleagues who are a bit older who feel that they can do these injections without actually needing high-level ultrasound or X-ray guidance. I'll show you some pictures later on, but that's just not possible. You need to be very precise with your treatments. You need image guidance. You need to your physician needs to also understand how to use inflammation to help you heal. Chronic inflammation is a problem and is bad. Acute inflammation, generally, if you've had an injury, is good because it's your body's way of trying to heal from an injury. There's some exceptions to that, but usually that's a good thing. And regenerative medicine helps to utilize that inflammation on a very local level to cause that to happen. They should also understand the different types of biologic treatments that are used. There's a lot of subtlety to this. To be an expert, you need to understand that subtlety. They should give you a bespoke or personalized treatment plan versus a one-size-fits-all. If you're getting the same treatment that the last 10 people have had done, that's not a personalized treatment plan, and I don't recommend that. They should understand prolotherapy and how to treat instability. I'll talk more about that, but prolotherapy is where you're injecting into the soft tissue structures around the joint to help strengthen the overall joint. They should be transparent regarding results and your candidacy for treatment. Not everyone's a good candidate, and some people who may be good candidates, you need to be honest about what the results are as well. They should also follow your results long-term. That's very important. This should not just be a one and done process. They should really want to know how you're doing 5-10 years down the line. And lastly, they should guide you through the process. These treatments, I've been doing this since 2008, but they're still considered relatively new. Patients have a lot of questions, and guiding you through that process is important. So is this legal? Simple answer is yes, if you follow strict guidelines from the FDA. That means you need to use your own cells. You need to process cells and inject them the same day, and you need to use this for musculoskeletal conditions and nothing else. If you're following those rules, then these treatments are legal and appropriate. Next question is, if I'm older, shouldn't I use someone else's cells? Absolutely not. For most orthopedic conditions, there's good evidence that using your own living cells is effective. You don't have the risk of using somebody else's own cells, And on top of that, really the data is based on using your own cells. Stick with what the science shows. Is there an age limit? Nope. The results for most areas are that regardless of age, you can still do very well with treatment. The one exception are hips, where age over 60 to 65 can be more challenging in those people. So what sort of doctor does these treatments? I talked about this. They should be a musculoskeletal expert. They should be a non-surgical musculoskeletal expert, and they should be an imaging expert, and they should really be finely focused and an expert on all those other things that I listed. So can these treatments help if I've already had surgery? If you've had arthroscopy, if you've had a ligament that's been torn, or a tendon that's been torn, that's been repaired, yep, absolutely, these treatments can still help. Some evidence that these treatments can actually prevent future problems if you've had those surgeries. If you've had a joint replaced and you've got hardware in the knee, that's different. Then generally do not recommend these treatments. My general rules for patients who need orthopedic surgery is try to keep your own anatomy if possible. Avoid surgeries that are only cutting out tissue because that leads to more instability, and always consider a regenerative medicine treatment option if you recommended surgery to see if you can still benefit. So we're going to talk about some of the other key regenerative medicine concepts. Stability is unbelievably important. Tensegrity is this concept in architecture, which means that if you take individual units that separately and individually are weak, but if you put them in close approximation to each other and under compression, you can have an overall functional unit that's much stronger. And biotensegrity is that same concept in biology and in medicine. Prolotherapy is the idea of injecting your own cells into soft tissue supportive structures to strengthen and stabilize them. The key there is that if you're treating, let's say, a knee joint, you don't just treat the knee joint, you treat all the layers above that. And that includes the meniscus, the ligaments, the muscles, the tendons, the myofascial tissue, sometimes the peripheral nerves, treating all those layers and depth of treatment. What you'll get is progressive strengthening over time, which will then give you a longer lasting result in terms of pain relief and functional improvement, because you're actually treating what's driving the problem, which is instability usually. So here's a case study of a lower back, 71-year-old man who'd had a lumbar laminectomy in the past, ×2, still having pain. We ended up treating with platelets his lower back ligaments, facet joints, muscles, and epidural space. One treatment gave him 30% pain relief. We ended up escalating to using his own bone marrow stem cells. We've gotten him up to 75% improvement, and he's still doing well and functioning much better. So orthobiologics, these are the biologic cells and tissues that are injected with these kind of treatments. And we'll talk about some of the main kind of ones, but these use a normal healing process that I discussed before. Again, use your own cells preferentially versus somebody else's. Platelets. So after an injury, platelets recruit other cells and growth factors to assist in repair. That's how they work. They use focal inflammation to help repair tissue damage. The growth factors from your own platelets stimulate your own local stem cells. There's different types of platelet preparations. Again, if your physician is just doing a one-size-fits-all process, you may not be getting the right treatment. So if you see the picture on the right, there's two different types of platelet-rich plasma there. The one on the left that's amber or yellow colored has essentially no red blood cells, just a high concentration of platelets. That's what you want to inject into the joint and the tendons. On the right, you have red blood cells in the platelet-rich plasma, much more inflammatory. You don't want to inject that into the joint. That can sometimes help in muscles, but preferentially, you want to be getting platelet-rich plasma that's like the one on the left, that's amber colored. Platelet lysate is another type of platelet-rich plasma where now we're taking the platelets, cracking them open, and taking the growth factors and injecting that around tendons and ligaments. The key here to understand is that different types of platelets will fit different types of problems. You need that kind of approach to get a very personalized treatment approach for your particular issue. So this is a case study of a man who's got knee tendinitis. He's a 45-year-old man. He's a cyclist. Was referred to me by his sports medicine doctor because he had persistent left knee pain despite physical therapy. His ultrasound also confirmed that he had patellar tendinitis. To give you a sense of what that looks like, on the lower right image, that is an ultrasound. That is the patella, the kneecap. This is the patellar tendon. These little calcifications or white-colored streaks, these are essentially bone spurs within the tendon, consistent with patellar tendinitis. So in his case, we ended up doing platelet-rich plasma treatment 2 times. The picture on the right is, again, an ultrasound. That's the kneecap. That's the needle. And this is where we're injecting into the tendon sheath, right at the origin. So after 2 treatments, he was able to return to full activities and did great. 3 years later, I saw him. Now his other leg was having issues. He had a hamstring issue. Again, treated him again with platelet-rich plasma, and he did great. To me, it's a good example of where platelets can work very well for a lot of conditions, mild to moderate conditions, and how you can utilize it multiple times and still get great response. So stem cells are the next cell line that needs to be considered. They are the main cell that really helps to drive and coordinate the healing process after an injury. You want to use your own cells rather than somebody else's cells for safety and legal reasons. In the United States, bone marrow-derived stem cells are what's legal. Fat stem cells are not considered legal. You can use fat or adipose for structural support, but strictly speaking, you cannot use them for stem cells. And the reason why is because the enzyme utilized is something that the FDA has concerns if it's being re-injected into humans. You may have heard about amniotic or umbilical cord cells. There's no living cells in those. You should ignore that. They can help because they have growth factors, but they don't have any living cells. So it's not a true stem cell treatment, not as strong as platelets or your own bone marrow cells. IV stem cells, you may be hearing more and more about this. There's no proven benefit for orthopedic conditions, may help with other issues, but we're focused on orthopedic issues here. So that's what we're talking about. So in terms of outcomes, can we improve pain and function even when someone has advanced conditions? And the answer is yes, we can. So what about imaging findings? So if you have advanced arthritis, I can't get your x-rays to look like what they were 20 years ago. It's just not possible. You'll still get pain relief and functional improvement. You'll also get a improvement in life in terms of overall life and quality of life, but I can't get your x-rays to look what they were 20 years ago. We don't have that kind of technology. If you have a tendon tear or ligament tear, and as long as the tear is not separated more than 2 centimeters, yep, we can still improve that on imaging and as well as in pain and function. If you have swelling in the joint, we can improve that. If you have swelling in the bone, we can improve that. So there's a lot of things that we can still improve in terms of X-ray and MRI findings. But when it comes to more chronic arthritis, it's more about improving pain and function. So can we treat bone-on-bone arthritis? Simple answer is yes. Arthritis is a biologic condition. It's treatable with these treatments. And in particular, if your range of motion and function are still intact, good outcomes are still possible. A couple caveats. Number 1, cannot necessarily change how your imaging looks. Number 2, hip arthritis, when it's more advanced, is more challenging. Other joints, if they're even advanced, are still possible to be treated. And while pain and function can be improved, improving imaging is unlikely, as I mentioned. So this is a good case study of an ACL tear. Can we treat ligament and tendon tears? So if there's a partial thickness tear, definitely. If there's a full thickness tear, this is an example of where we possibly can. So this is a 28-year-old man. He's a butcher. He's a regular person. He had an ACL tear while he was playing recreational volleyball. I saw him 2 months later. We did a bone marrow stem cell treatment in his case. And 3 months later, no longer having pain, and he was starting to do more dynamic activity through physical therapy. Let me just show you a couple of things on this image on the right. So this is a X-ray image, fluoroscopy image. This is the thigh bone. Sorry. This is the shin bone. This is the patella or the kneecap. This is the needle. And this right here that's being lit up is the ACL. We're injecting a little bit of contrast in there to confirm we're in the right spot. After we confirm we're in the right spot, then we inject his own cells into there. So what's really great is just see what these MRI findings, how they've improved. So the MRI on the left is before treatment, thigh bone, shin bone, kneecap. That's the ACL, so before treatment. Very disorganized, very hazy. Radiologists call this a full thickness tear, and it's pretty badly damaged. The MRI on the right side, again, thigh bone, shin bone, kneecap, here's the ACL now. Here you can tell the ACL is a very clear structure, linear, very well-defined, essentially a normal ACL now. And the radiologist has called this essentially a normal ACL, right? And that's after treatment. That's a very exciting that not only did he have a great clinical outcome in terms of pain and function, but he also had a great imaging outcome as well. So this is the next case. This is a 57-year-old man. He's a contractor, general contractor. He had significant pain in his shoulder due to a rotator cuff tear. And he ended up undergoing the bone marrow stem cell treatment protocol where he got his own bone marrow stem cells and platelets injected. Again, great response. So ultrasound image on the left, the top and the bottom, that's the tendon. That's the tendon. That's the tear, the black space, that's the tear. On the right, this is after treatment, 3 months. He's doing great clinically in terms of pain. That's the tendon, that's the tendon. Here's where the tear previously was. You can see that it's being filled in now. So again, not only a great clinical outcome, but also really a nice healing imaging outcome as well. So interventional orthopedics is the process where we utilize image guidance to treat orthopedic conditions. The idea here is that we need to be very precise with what we're treating. And let me show you what that looks like. So picture on the left is ultrasound. That's the supraspinatus tendon, the rotator cuff. That's the needle. This little area is where we're injecting his cells. This is a zoomed in screen. All right, so it looks pretty big, but in real life, that is less than, that's about 1 by 1 millimeter in size, very small. You can't inject that blindly, right? You have to be able to utilize the imaging modalities we have in the office. Picture on the right, that is the humeral head, glenoid, this is the shoulder, that's the needle. How do we know we're in the joint? Well, number one, we have a little bit of contrast that we inject before we inject cells. And then how do we know we're hitting the labrum? Well, there you go. That little triangular structure is a labrum. We've lit that up with contrast, and then we're injecting cells in there as well. The keys here are you have to use image guidance. I have colleagues who think that they can do these treatments without image guidance. And if you're trying to hit something that is 1 millimeter by 1 millimeter in size, coming from the skin all the way down pretty deep, you know, that is fishing for a needle in a haystack. And you know, as I tell my patients, until I have X-ray vision, I'm using the ultrasound and X-ray that we have in the office to help guide our treatments. So I showed these pictures previously, but the ultrasound image on the left is a patellar tendon injection, and the image on the right is an ACL injection under fluoroscopy or X-ray guidance. You cannot do that blindly or even with ultrasound. You can only do that one with X-ray. This is a case of a 41-year-old man. He's a chef. He had significant pains in his left ankle just from standing for 10, 12 hours at a time, essentially diagnosed with early osteoarthritis as well as avascular necrosis. So the image on the left, that's swelling in the ankle bone. That is avascular necrosis where the bone is dying. As that bone dies, the joint, the cartilage above it, or that's above the bone is starting to die as well. So we injected his own bone marrow cells into the joint and into the bone. 3 months later, here's his MRI. That white signal indicating that the bone is dying has been resolved. He's doing great clinically, and he's also doing great from an imaging standpoint as well. And the goal is to really prevent this from progressing long-term in his case. Regenerative medicine treatments offer safe and effective solutions for your pain. See, there's a question here. Will you address bone-on-bone knee issues? I just did. Okay, so advanced knee arthritis, the evidence shows that even if you have advanced knee arthritis, utilizing your own bone marrow stem cells can still give you a significant degree of pain relief. That average degree of pain relief is roughly 65% at the 1 and 2 year mark. Those are realistic results in people that have advanced arthritis. And so knees are made differently than other joints in our body. They're very hardy. They can take on a ton of stress. And so even when people have advanced arthritis, they can still do incredibly well. And so I hope that helps to clarify that. So is this too good to be true? So there's evidence from Philip Hernigue, Dr. Philip Hernigue, since the 1990s. He's a French orthopedic surgeon that's been doing this. He actually has studies where he compares knee surgery on one side and stem cells on the other side, or shoulder surgery on one side and stem cells on the other side. And his data is very convincing and very suggestive that using your own bone marrow cells can be a great option in a lot of our patients. The Regenix Network has data since 2005. I've been doing this since 2008. While this field is rapidly developing, it's not new. I have colleagues. It's interesting. I've been doing this long enough now where when I first started doing this 15 years ago, I had orthopedic surgeon colleagues who would ask, is this legitimate? Does this work? And 15 years later, their feeling is that they're still not sure about the results, but they think it could be helpful. And the reality is that there's enough data over the last 20, 30 years to show that these treatments work. And it's just the difference between someone who's in this every single day and has the experience versus someone who is new and really not fully aware of what's going on in a different field. There are definitely right and wrong ways to do this. Your expectations should definitely be grounded in reality and evidence-based medicine. I see some more questions coming through, and I do see them. I will get to your questions as we continue on. Or let me just kind of chug on through this though. So how long do results last? Regenix has data that goes over 10 years. Philip Hernigue has data that goes over 20 years. What I tell people is think conservatively though. If you have a chronic condition, like you've been living with knee pain for 10 years, expect that you'll need a repeat treatment at some time. That might be another bone marrow stem cell treatment in 5 years. It might be a booster platelet treatment a year down the line, but expect that a repeat treatment somewhere down the line will be helpful. The good thing is that these treatments give a more durable response than the other kind of injections that are available, whether gel injections or steroid injections. And it's because they're working on the source of the problem, which is cells that are not working well, instability, chronic inflammation. In addition, you get a stair-step improvement, meaning if you get a steroid injection, you get immediate improvement, and then it comes right back down, back to baseline. With these kind of treatments, orthobiologic cell treatments, you get improvement, you'll be at a baseline. If you get a repeat treatment, you're now building from that higher baseline, and you're getting higher than that as well. The best way to maintain results after treatment, improve your biomechanics, continue to exercise, take the appropriate supplements, maintain ideal body weight, as well as ideal metabolic health, inflammation, and repeat treatment as needed is additive to initial treatment. Cost, these are not routinely covered by insurance. The exceptions would be self-insured companies that have added this to their benefit plan. If you work for such a company or you own such a company, go to regenixcorporate.com and they can help guide you through that. Cost estimates in the US are as follows if you're paying out of pocket. Platelet-rich plasma, it's roughly $2,500. Stem cells, it's roughly $8,500. What I recommend is the keys to determine the value of treatment are, number one, are your physician and clinic regenerative medicine experts? Number one, are you receiving a real stem cell treatment or something that's been mislabeled? And understand that these are in-office procedures, so you don't need to go to the hospital or surgery center where there's more even add-on facility fees. So we talked about this before, about what makes a regenerative medicine expert. I hope it's clear that there's really quite a few things that make somebody a proper expert. It's not just being remotely involved in this that makes you qualified to do this. It's really being dedicated to regenerative medicine to do this properly. A little bit more about how we function here at Chicago Arthritis and Regenerative Medicine. Completely focused on non-surgical treatments for your arthritis, tendinitis, injuries, and back pain. Evaluation, looking at inflammation, instability, asymmetry, and their muscular issues. Correcting with low-risk interventions as possible. If not working, then if appropriate, utilizing regenerative medicine treatment, using the best possible products from yourself, plan that is specifically tailored or bespoke to you, and injecting cells, delivering cells using the highest level image guidance possible. Let me just catch up on some questions here. So, all right, question about, can you comment about treatment for growing excessive osteophytes? I'm trying to find a solution. So osteophytes are essentially bone spurs. You see them in wear and tear arthritis. There's a mistake to think that osteophytes are the problem. Your osteophytes are not what's causing the pain. So if your body has had damage in a tissue and it cannot repair it, and there's instability there, the body's only way of reacting is by putting calcification in there to create a little bit of stability. And that's what an osteophyte is. And so in the past, those osteophytes would get cleared out. The problem is that it would just lead to more instability. And so more appropriately is you treat the instability and you treat the chronic inflammation. And that's where you utilize regenerative medicine for those kind of things. So you don't actually cut out the osteophytes because that's not what's driving your pain. That is just a sign that there's instability there. It's by treating the actual cause of what's driving your pain. That's how you treat it. Somebody asking about arthritis in both knees. Okay, well, we'll give you some details about how you can make an appointment. Essentially, there's a few different ways, and you'll get that in the chat, but you can either go to chicagoarthritis.com. Alternatively, you can email us at admin@chicagoarthritis.com. You can also call us at 773-348-7171. Also, if you go to the website, chicagoarthritis.com, there is actually a way that you can automatically schedule a telehealth appointment. That'll get into our schedule as well. Okay, next question, somebody else asking about, can you inject this into the cartilage? Yeah, I mean, again, the cartilage is essentially that layer that lastly gets damaged in the joint. So we end up injecting directly into the cartilage as well. In addition, for people that have certain conditions, we'll actually end up injecting into the bone as well. That supplies the cartilage also. So we're definitely hitting all those spots. Okay, so I see someone, again, the issue with the osteophytes. If you've had surgery and they've removed the osteophytes, again, regenerative medicine is still a good option, assuming they did not put any hardware or metal into the knee. Yes, I am the physician that treats. I'm not just the spokesperson. I am in fact the physician and the one who does the treatments here. A little bit more about how we kind of work here at Chicago Arthritis and Regenerative Medicine. Integrity is, I think, everything to how we do things here. Integrity in terms of how we work professionally and how we work with each other. Respectful and collaborative care. You need to understand what you're getting in terms of treatment, what your candidacy is, being very transparent about a candidacy for treatment, being transparent about cost of treatment as well, offering the best options available. Fact is, I end up treating a lot of my own family members, whether it's my parents, my in-laws, friends as well, colleagues as well. Same treatments that we're offering them are going to be the exact same treatments and the exact same decision-making that we have for patients as well. We deserve the best option, not just the most convenient option, and always doing what's right for the patient in terms of giving you the best treatment options possible. Okay, a few more questions coming in right now. Okay, well, no, these aren't questions. These are just thank yous. You're welcome. Appreciate it. I appreciate everyone's time today as well. Wonderful. Well, if there's any other questions, please let me know. If not, I will start to wind down here, and we're available to assist with any other questions offline or available for evaluations in the future as well. And if we can be of additional assistance in the future, please let us know. I appreciate everybody's time. I hope everyone stays healthy and well. And until we connect again, be well and live well. Thank you very much. Bye-bye.